technical difficulties here. Okay, so a couple of things, a couple of housekeeping items before we get started. The following message is not for you because you're here. So thank you for being here. I know how painful it can be. Trust me, okay? You know, I try to make it as enjoyable as possible, but I do know it can be difficult. But more for your colleagues who aren't here, who might actually listen to this recording, just remember something, okay? Attendance is not mandatory, but it is expected, okay? I always tell students, if they're not sure what to do, treat this just like your job, okay? You wouldn't just not show up to your job one day and not say anything to anybody. You know, you know me, I am very, very easy with that kind of stuff. I'm very forgiving and, you know, and very flexible because I know that life can get in the way a lot with things that you're doing. If you need to miss, I would just ask that you let me know, okay, folks who aren't here. I'll be sending an email out around as well, too. If you need to miss, I get it, okay? But attendance has been a little bit sparse, and that's not something you want to get into the habit of going through this semester because it can be, it's intense, and there's a lot of stuff to learn, okay? I know I'm preaching to the choir because you're here. I appreciate you being here. Encourage your classmates who aren't here to be here, okay, as part of their professional responsibility. And if they can't, it's okay. Like I said, there'll be days you may not be able to be here for whatever reason. You're sick, you've got family responsibilities, you're stuck in traffic, flat tire, whatever it happens to be. I get it, okay? Just let me know, because if I'm here, I want you to be here, all right? So we can all suffer together, right, in our learning. That's a terrible thing for me to say, but at any rate, kind of tongue-in-cheek. All right. So today, I talked to Dr. Naeem. There's no way she was going to be able. I usually have 2 days scheduled for this lecture because there's just so much material when we're dealing with ischemic heart disease. You know, we're talking about, you know, a lot of drugs that impact cardiac work, and you know, getting into the drugs that really exclusively improve coronary blood flow by either preventing clots from forming or by breaking down unwanted clots that are occluding coronary vessels. So again, what I told you yesterday, just as a quick recap, if I can get my PowerPoint working here, and this is going to be an easy fix. I'm just going to bring the cursor. Where's it at here? There's my cursor here. Okay, great. Now it'll work. All right. Remember I told you, okay, this should be the foundation of your learning. There's so many drugs and so many different mechanisms of action, and it is so easy, you know, to have your mind kind of explode as you're looking at all this. I get it, right? So the thing that you really need to do, and your mantra for studying this, is start big. Okay, start big and work small. And this is where you start right here. Okay. Understanding that our primary pharmacological strategies for treating ischemic heart disease, okay, is one of two things, or both, okay? We're either going to use drugs that improve coronary blood flow, okay, so that we can improve oxygen delivery to cardiac tissue, or we're going to use drugs that reduce cardiac work, okay, the work that the heart is doing. Remember, the heart is an organic pump. It works, all day, 24 hours a day, 7 days a week, 365 days a year for your entire life. It never stops. It never rests. Okay, so it does an incredible amount of work, and it requires a lot of, frankly, resources like oxygen and energy. Okay, and the coronary blood supply is what supplies it with oxygen and nutrients and things that it needs to continue to work. So remember, ischemia, which is a condition where there's inadequate blood flow to meet the demand of the heart, it usually is caused by some sort of imbalance in these two factors here, right? You might have, an occlusion in the coronary blood vessels and an increase in cardiac work, and all of a sudden that equation gets out of balance and you start to run into trouble. And Dr. Naeem is going to talk to you about that tomorrow, okay? Some drugs, okay, do one thing. Some drugs do both, right? But start there. We talked about, for example, drugs that reduce cardiac work. We talked about nitrates, non-dihydropyridine calcium channel blockers, beta blockers, ranolazine. And if you think about, okay, how those drugs work and reduce cardiac work, they all do it differently, don't they? Okay? And this is kind of where the complexities come in. So again, cardiac work is expressed as cardiac output, the amount of blood pumped by the heart per minute. And it's a function of heart rate and stroke volume. Heart rate obviously reflects how many times the heart contracts or goes through a cardiac cycle per minute. And stroke volume refers to the amount of blood ejected by the left ventricle every time it goes through contraction or systole. Okay? And when you combine the two together, you get a sense of how much blood is being pumped throughout the systemic circulation per minute. That is our primary gauge of cardiac work. So again, starting with that, we know that anything that will reduce heart rate or reduce stroke volume, okay, can reduce cardiac work. Questions? Yes. What's up?
I have a confusion with the NTP calcium channel blockers.
Yep.
Because in the models and the indication, it says the dihydropyridine calcium channel blockers are for ischemic heart disease. But here, I'm seeing the NTPs.
Yeah, so the dihydropyridine, and Dr. Naeem is going to cover this. I think the key piece with the, and I don't include them up there, but she's going to talk about them, the dihydropyridines. You were looking at the guidelines, right?
Yes.
And it says that they can be used.
It specifically says the dihydropyridines, while the NDPs it allocates there for arrhythmias and hypertension.
Yeah, so I'll talk with her about that in terms of what the current treatment guidelines is. But if you think about, for example, dihydropyridines, right? What we don't want to do in a situation where a patient has conditions that set up ischemic heart disease is to do anything to rapidly and unexpectedly increase heart rate, right? So using a quick-acting, powerful vasodilating agent, like nifedipine, medium release, right, could cause reflex activation of the sympathetic nervous system and an increase in heart rate that could contribute to mortality. You could have someone who has a heart attack because of that. Okay, probably more slower acting dihydropyridines that reduce afterload will reduce the amount of work that the heart has to do and can be used as well too. Non-dihydropyridines, as far as I know, are used for this, okay, because they reduce afterload like we talked about. So again, reduce the resistance to blood flow, but they also lower heart rate and stroke volume. And again, the combination of those things reduce the amount of cardiac work that occurs. So when you start talking to Dr. Naeem tomorrow about the guidelines and things like that, that's a great question to ask her. Okay, I know that I'm like you said, the dihydropyridines I don't talk about, but I'm pretty sure they can be used for ischemic heart disease. Again, you just want to be very careful about the ones you select because that reflex activation of the sympathetic nervous system, which can lead to tachycardia, not great for somebody with coronary artery disease, right? Okay, especially if they're experiencing, angina or they've got other issues like that. Okay. Again, I'm not a clinician, but that is, that's my understanding of that. But good question. Okay. So again, but all of these drugs work differently. They have different mechanisms of action, but they all contribute to reducing cardiac work either by reducing afterload, reducing heart rate, or reducing stroke volume in different ways, right? Okay, so that's the way to frame that, okay? If you understand that, okay, there's these 4 different groups of drugs that reduce cardiac work, okay? Cardiac work is is reflected by cardiac output, okay, and afterload. And anything we can do to reduce cardiac output and afterload will reduce cardiac work. That gives you a basis to work from with these. And then digging a little bit deeper, understanding that, for example, the nitrates, the way that they work to reduce cardiac work is that they certainly cause vasodilation, right? Dilation of our arteries and systemic circulation, but they also cause venodilation. And as the veins dilate and venous capacity increases, the amount of blood that is going back to the heart, which is also known as venous return, begins to decrease. And that in turn will lower preload. And if we lower preload, stroke volume goes down. Okay? So again, very unique mechanism of action. We're reducing stroke volume and afterload with the nitrates. Beta blockers, right? We know beta blockers, again, from a very basic standpoint, okay, depending on the kind that you use, will at a minimum reduce heart rate and stroke volume by blocking the effects of the sympathetic nervous system on the heart, right? That will reduce cardiac output and cardiac work. Some of the beta blockers also have alpha blocking properties, and even those that don't, through different mechanisms, can reduce afterload or systemic vascular resistance, okay? So if you talk about a drug like labetalol or carvedilol, those drugs have alpha-1 blocking properties which will, again, relax arteries and reduce systemic vascular resistance. I don't know if they're used in the treatment guidelines or not. Frankly, I don't know what beta blockers are used. I don't remember exactly which ones are used for ischemic heart disease, but Dr. Naeem will talk about those. And again, as you talk about specific beta blockers, it's really important to figure out whether they just have beta receptor blocking capacity, or are they like labetalol or carvedilol, which is the only two that I know of that have beta blocking and alpha blocking properties, okay? Up here, improving coronary blood flow. Again, there's a lot of different ways, okay, that we can improve coronary blood flow. A very basic way is to actually increase the size of the lumen of our coronary arteries by getting them to dilate or relax, okay? And there are drugs that will do that directly, okay? Like our nitrates and our non-dihydropyridine calcium channel blockers, okay? We also have a drug like ranolazine that will improve coronary blood flow, but not due to a direct effect on the coronary arteries, but rather its effect on cardiac muscle and getting it to relax, especially during diastole, okay? And that relaxation of the cardiac muscle helps to it helps to relieve some of the strain on the large surface coronary arteries that are flattened out a lot if the cardiac muscle tissue is tense, and allows those blood vessels to regain a more of an oval shape or open shape and improve blood flow. So again, different mechanisms of action, okay? Today we're going to finish up with our drugs that can affect coronary blood flow, but by blocking the hemostasis, the process of hemostasis, which is the process of arresting bleeding. So let's talk a little bit about this here. We'll get back to our where we left off here. Again, remember we talked about yesterday towards the end of class. Just a recap. We talked about the definition of hemostasis, right? And it's a process by which the body spontaneously blocks or arrests bleeding from a blood vessel wall, okay? Hemo meaning bleeding, stasis meaning stop, okay? And many of our drugs that we are going to talk about actually block this particular system in order to either prevent the growth or formation of clots in the coronary arteries, or in the case of the thrombolytics, actually breaking down clots that have already formed, okay? The hemostatic system has physiologic and biochemical components to it. It's very complex. So there are tissues that are involved in this, like the blood vessel wall, okay? And the blood vessels themselves are an important part of the hemostatic system, but we also have things like platelets, circulating platelets, as well as clotting factors that are part of the coagulation cascade. And all three of these things work together to generate or form clots in the body when bleeding occurs. We also have the fibrinolytic system, which we'll talk about briefly today. This is the body's own natural enzymatic system that works to limit the growth of clots and break clots down that are no longer needed. They're kind of like the cleanup crew. All right, so if you have a clot that's formed that is no longer needed, your body should be able to get rid of it, and it uses a small group of enzymes that make up the fibrinolytic system to break it down. The fibrinolytic system is also very important in just limiting how big clots get when they form. Without the fibrinolytic system, again, you could theoretically cut your finger and your blood could clot all over the place. You know, you could get total systemic clotting and die. All right. So the fibrinolytic system certainly is very important for that. All right. We talked about primary versus secondary hemostasis. Today we're going to talk about both, but we're going to spend the vast majority of our time talking about the primary hemostasis, which involves platelets. Okay. The primary hemostasis is again a process by which platelets are recruited to the site of damage in a blood vessel wall. They begin to collect and stick to that damaged area and aggregate together to form something called a platelet plug. This is a very basic type of arterial clot. It's not terribly strong, but once secondary hemostasis kicks in, which occurs on the surface of platelets, what we get is the formation of fibrin strands, which will reinforce and strengthen that clot. And so we get a nice, strong clot that, again, can prevent blood loss from the body. And that's normally a good thing, but if that clot gets to be too big or it forms on top of an atherosclerotic plaque that is ruptured, what can happen is you can occlude blood vessels and prevent blood flow from reaching certain areas of the body, or in the case of ischemic heart disease, certain areas of the heart. Okay, everybody following me there? Okay, very dynamic process, very interconnected. All right. And again, a thrombus or clot, and I'll use those two words interchangeably. Again, is made up of different things depending on whether we're talking about arterial versus venous clots. And we're going to talk about that in a little bit, okay? And that's super, super important because if you understand how an arterial clot differs from a venous clot in terms of its composition, it makes it very easy to understand why we treat them the way that we do, okay? There's no guesswork or memorization. You can understand it and figure it out. All right. So we started talking about the kind of steps of hemostasis, and one of the first things that occurs after a blood vessel is damaged, and blood vessel damage can occur due to traumatic injury, a crushing injury, a cut, or other type of injury, or it could simply be caused by an unstable plaque that has ruptured. Those are two kind of major examples of traumatic injury that can occur, or injury that can occur to a blood vessel that will kick off the hemostatic process. And one of the first steps of hemostasis is vasoconstriction. So what you'll see is that as the blood vessel wall is damaged, either through rupturing or through some traumatic type of injury, it will release substances from damaged cells, will release substances that cause your blood vessels to constrict in the area of damage. And the whole purpose of this is to help limit blood loss. It doesn't stop it completely, but it will help to limit the loss of blood from that particular site. And again, a lot of it depends on the size of the injury and how severe it is, and so on and so forth. But vasoconstriction is certainly something that's important, okay? Now, again, if you stop and think about it just for a second, right? Let's say you're someone who has atherosclerotic disease in your coronary arteries, okay? And let's say one of your coronary arteries has a pretty sizable plaque in it. It's unstable, and currently it's blocking 50% of the blood vessel. You're still getting blood flow through it, but it's been cut in half. And let's say that plaque ruptures because it's unstable and starts releasing substances that cause vasoconstriction. What's going to happen to that coronary artery? It's going to start to clamp down on that plaque, okay? And between that and the clotting that's going to occur very quickly, you could very quickly cut off blood flow to a section of the heart, okay, in that way. That's why, again, quick action on this is certainly very, very important if that's actively happening to somebody, okay? Now, we're kind of left off here with this mess of a diagram that kind of shows the different steps of the clotting pathway that involve platelets. Well, I'm going to go through this here, okay? And what I would like today, okay, if you don't mind, is can I get 6 volunteers to come forward and come on down here forward for me? Just 6 volunteers to help me act out hemostasis. I like to do this. Don't be shy. I will tell you everything you need to do, okay? Your classmates can video record it, put it on YouTube, and you'll be famous forever. I need 6 people. Come on now. We're not going to do that. We're not doing that. We're not doing that. I'm just kidding, okay? Thank you. All right, Carlos coming down. All right, great. All right, now, so what we're going to do is we're going to act out the process of hemostasis as it's seen in this particular picture and, and the information through here, okay? And you guys will actually learn it as you're going through. We'll go through some of the very basics here, and then we'll get into some of the details. So let's start over here with number 1. So what we're going to do, we're going to set up the scene here, okay? This empty pathway right here in the front of the classroom as I'm walking, pretend that's the inside of an arterial blood vessel, okay? This is where the blood's flowing, okay? I also want you to pretend that these chairs right here, okay, are endothelial cells that are making up that inner lining of the blood vessel. The endothelial cells are very smooth. They release nitric oxide and prostaglandins and things like that keep anything from sticking to them. So, because we don't want that to happen. We want our blood vessel walls to be super smooth and slick, and things that are circulating by, we don't want them to stick to it, to keep the blood vessel open. Okay? Now, what we're going to do here is we're going to pretend that this blood vessel has suddenly been damaged right here. Okay? Pretend this is kind of a hole in the blood vessel wall. Everybody can see that? Okay? Now, can I get one of you guys come on over here? Come on over and would you mind sitting on the steps there?
Sit.
Yes, sit next to one another on the steps. Okay? All right. Now, you guys are going to be my subendothelial glycoproteins. All right, so underneath all of these endothelial cells, and you can't see it when the endothelial cells are intact, okay? But there are these large glycoproteins. Glycoproteins are large proteins that have a protein component to it as well as a carbohydrate component. Collagen and von Willebrand factor are 2 types of glycoproteins that exist normally under the surface of endothelial cells. But when those endothelial cells are damaged, now what happens is these glycoproteins get exposed to the blood. And they're not supposed to be, okay? They're not supposed to be. All right, there we go. I love it. All right, now, let's pretend that I am a lone platelet floating along in the bloodstream looking for trouble, okay? I'm floating along here. Everything looks good here, nice and smooth, nitric oxide, prostaglandins coming out of here. All of a sudden, I come to right here, okay? And these glycoproteins are sticking out into the bloodstream. And what happens is I will stick to them like this, okay? This is like step 1, all right? This is adhesion. I'm adhering here, okay? Now, I'm a lone platelet, all right? Am I able to plug up this hole by myself? No, absolutely not. I need help, right? So what I'm going to do is, as I have specific protein receptors on my surface, all right, that will bind to these glycoproteins. And when that happens, what I start to do is I will start to release chemical signals out into the bloodstream. And that's like calling for help. Okay? Got it? So I'm like the first ambulance on scene at a major car accident. All right, it's just me and my paramedic. There's 15 casualties. We can't handle all of them, right? First thing I do is I get on the radio and I call for backup, right? So I need backup, I need help, okay? So you 4 are gonna be my platelets. Come on over here, okay? All right? You're gonna be additional platelets, okay? Get behind Shawnee there, all right? We're gonna just come one at a time. All right, so I'm floating along here, right? And I come across here and I'm attaching myself to these subendothelial glycoproteins. You see that? It's kind of step 2 there. I get activated when I attach to these proteins, and then I start releasing chemical mediators calling for help. And these are things like thromboxane A2, serotonin, and ADP. And I'll go through these in a minute. So as Shawnee's coming by here, she's going to come into contact with those chemicals, and she's going to become activated and aware of the damage. So she's going to come over here, okay, and bind to this glycoprotein, and you're also going to link with me and form a cross link, okay? All right, now you guys, George, come on over here, okay? You're gonna do this, and you're gonna do the same thing, and Kingsley's gonna do the same thing, and Carla's gonna do the same thing. Make room for everybody. So you see how we start, as one's recruited, additional platelets get recruited, and we all will bind and bind to one another. And now we've got a stable platelet plug, right? Okay? Now, what will happen here very quickly is on our surfaces, once we form this plug, the coagulation cascade will start activating, okay? And what will happen is we will pretend that we are all tied up with a rope together and tied to these glycoproteins. So we're stuck here, we're stable, and we're strong because we're all linked together like this. Does that make sense to everybody? Okay? So this is how clots form. And normally it's a good thing, we don't want to lose blood. But imagine this happening in a coronary blood vessel, right? And imagine if the rest of you came down here and acted as platelets and started attaching yourself to Carla, Kingsley, George, Shawnee, and myself. Big clot starts to form very quickly. And guess what happens to blood flow? Gone. All right, so let's give our participants a round of applause here. Thank you very much. Volunteers.
To me.
Yeah. Okay. And that's, I mean, if you can visualize that, did anybody find a really good video yesterday or nobody looked, cared to look? Yeah. There's some animation there. Again, you can look on YouTube. If you find something really good, send it to me. I'll send it out to the class. But, you know, again, just for me, visualizing this process is so important, okay, to understanding what's going on. Who has questions about what they just saw? Anybody have questions about that? Okay, remember, blood vessel, go ahead, Ernesto. Yeah.
So, what's the name of
the glycoproteins,
yeah.
And it's a big word, right?
Subendothelial.
Subendothelial, meaning beneath the endothelial layer, glycoproteins. And there's specific examples of those we'll see in a minute.
So platelets bind to that, and that makes a cascade with
creates a cascade of events that occur, right? So when I'm the first platelet on scene here, okay, and I'm binding to my subendothelial glycoproteins, I get activated. I actually undergo a change in my morphology or shape, and I start releasing chemical mediators out into the bloodstream, which will attract more platelets. They come in, they start attaching to the damaged area and attaching to me, and they start to release their own chemical mediators. So now we've got even more chemical activators in the blood, which will recruit even more. It's almost exponential, right? More and more platelets get attracted and attached until the blood vessel wall is sealed up. And as that's going on the surface of these platelets, we have the coagulation cascade being turned on. And that will generate strands of fibrin, which will reinforce and strengthen the clot.
That's like different factors coming in.
Exactly. We're going to go through that. We're going to go through that today. You guys remember all the different clotting factors, but we'll actually get into that more in one of the subsequent lectures on venous thromboembolism, pulmonary embolisms, so VTE, PE lectures, which will be in a couple of weeks. Okay. Yes.
Clarification.
Yep.
So you said it's damaging the platelet cells.
Yep.
So what it's trying to do is trying to repair it, but creating a thrombus instead.
Yeah. So the thrombus is like a plug. Okay. So pretend you've got a hole. Let's say you're in a boat, right? And your boat hits something, and there's a hole in the wall of the boat, right? You got to plug that up before your boat sinks. That's essentially what's happening here. It's kind of a plug job, right? Or if you're in an apartment, in a dorm room, and you got a hole in your wall, right? That you got to patch up to spackle. That's essentially what this is like. It's a kind of a temporary patch job that will allow the blood vessel underneath to heal and those endothelial cells to grow back. And once that's happened, then the fibrinolytic system will come in and chew up the clot and break it down. Does that make sense? Okay? And again, like I said, this is a good thing. If we didn't have this, we'd bleed to death if we cut our finger, right? Okay? But in certain cases, it may actually be a bad thing, okay? Especially if you've got, again, a plaque in the coronary circulation that's unstable and the top of it blows off, right? okay? And it ruptures, and that process starts to take place on top of that plaque, okay? And that plaque can start, the clot on top of that plaque can start to get really big, really fast, and start to really occlude that blood vessel pretty quickly. Does that make sense? Okay, yes, sir.
So like what, like for example, like if a patient has like a hypertensive crisis, can that lead to like rupture?
Boy, that's a good question. So the question, if you didn't hear Ernesto, is if someone has like a hypertensive emergency or crisis, right, the blood pressure is right through the roof, could that potentially cause a plaque to rupture? I don't know. It could. That would be a really good question to ask Dr. Naeem. You know, in terms of what are the causative factors, right, that cause a plaque to rupture? You know, and certainly I would imagine turbulent blood flow over the surface of a plaque could cause it to rupture. And perhaps if you have a situation where blood pressure is really, really high, that could cause that to happen. So I would say, I don't know for sure, but I'd say that that's a pretty good guess that could be a causative factor, okay? Now, that's a very basic overview of this process. There are a lot of details that you need to know in order to understand how the drugs work, right? Okay? If, let's say, we want to prevent, okay, a platelet plug from forming in the coronary circulation, okay? We have drugs that will attack different parts of this process to prevent that from happening. So they have different mechanisms of action and different ways of inhibiting this process, which I'll show you in a second, okay? So again, you don't need to necessarily, this is a picture that shows all of this. You don't need to really worry about this if it's scary. You know, there are other pictures that I have that will show you the same process and lots online. So let's go through some of the details that I mentioned. All right, so for example, we're going to talk about platelet activators. These are things that take normal inactivated quiescent platelets that are floating through the bloodstream, not doing anything, and cause them to activate or turn on in order to repair or plug up a damaged area of a blood vessel wall. The two that I showed you in this example here were our subendothelial glycoproteins. Two specific examples of that are collagen and von Willebrand factor, okay? And there's that word there. And again, as you saw before, okay, they are responsible for that initial adhesion of platelets to the area of damage, okay? And also initial activation. When I came through here on the first platelet on the scene, I adhere to those proteins, and the process of me binding to them activates me. And I start to release certain chemical signals that will recruit and activate other platelets to help me out, okay? I mentioned to you before that there are specific receptors on the surface of platelets that will bind to these subendothelial glycoproteins, okay? And you can see that in number 3 and number 4 here, okay? Collagen binds to the glycoprotein 6 receptor that's on a platelet, and von Willebrand factor binds to a glycoprotein 1b receptor on the platelet. So again, there's specialized glycoprotein receptors on the surface of platelets that will bind to the subendothelial glycoproteins that are exposed to blood when the blood vessel is damaged. Does everybody understand that? And that's what causes adhesion and initial activation, okay? Now, I mentioned 3 chemical mediators, okay, and this is an oversimplified look at this, but these are 3 major chemical mediators that are released from platelets once they've been activated. Okay, so on the first platelet on scene, I bind to the glycoprotein, subendothelial glycoprotein receptors using my GP6 and GP1B receptor. I get turned on or activated, I start to release thromboxane A2, ADP, and serotonin into the blood surrounding me. And that's like my chemical way of calling for help. It's like getting on the radio or cell phone and saying, I need reinforcements, okay? Platelets don't have cell phones or radios, right? All they've got are chemicals, right, that they can release. Now, the first one, thromboxane A2, okay, is produced by the arachidonic acid cascade. Cyclooxygenase is the main enzyme that produces this chemical activator, all right? Do we know of any drugs that might inhibit cyclooxygenase and thromboxane production? Yeah, very good. Okay, so that we're starting to think in that way, all right? Thromboxane A2 and the rest of these mediators are released by a process of degranulation. So platelets have small spheres called granules inside of them that contain these chemicals, and when they need to be released, those little spheres or granules fuse with the platelet cell membrane and empty their contents out into the blood, okay? Now, thromboxane A2, two effects, and this is really important. It's a very powerful vasoconstrictor, okay? So if I'm here, and I'm that initial platelet, okay, and I'm starting to release thromboxane A2, not only will that chemical activate other platelets around me, but it also starts to cause the blood vessel in this region to begin to constrict, okay? And that's to limit blood loss. So it does two things. It activates platelets that are nearby so they can come and help me. It also causes vasoconstriction, all right? Now, the second major mediator is adenosine diphosphate, or ADP. You guys have heard of this before, right? It's a precursor for ATP, but it's also an important chemical signal, all right, or signal that is released from the platelets, okay? This particular chemical mediator will activate a specific type of receptor on the surface of platelets. That receptor is the purine receptor, okay, or P2 receptor, okay? So again, if I'm that lone platelet here, and I'm binding the glycoproteins underneath the endothelial layer, and I'm stuck here now, and I start to get activated, and I start to release chemical signals. I release thromboxane A2. That causes the blood vessel to begin to constrict here. It also calls in reinforcements, okay? I also release something called ADP, okay? And let's say Ernesto is a nearby platelet here. He's got ADP receptors or purine receptors on his surface that will be activated by the ADP that I release, and that tells him I need help, okay? Just like the thromboxane A2 does, okay? And then we have serotonin. I will also release serotonin. This again is another vasoconstrictor, okay? Helping to further constrict the blood vessel in the region of vascular damage, but it also will activate surrounding platelets and bring them in to help reinforce the plug that I'm beginning to form, okay? So we got three different chemical mediators here, that at least three major ones, that are involved in the recruitment and activation of additional platelets, all right, to help form that platelet plug, as well as two out of the three of them cause vasoconstriction at the site of damage, all right? Any questions about these specifics?
The ADP is going to send a signal that something is wrong.
Yeah, so the ADP is a chemical molecule, right, that platelets contain inside of them in these little granules, just like thromboxane A2, okay? And again, when a platelet gets activated because it's attempting to block a part of the damaged blood vessel wall, they will release ADP into the bloodstream. And that chemical molecule can activate a receptor on other platelets that are nearby and turn them on and say, hey, okay, Dr. Culhan needs some help over here, all right? And they're going to come and they're going to help form that platelet plug. All right?
Thank you.
You're welcome. Thank you, Mallory.
So, fibrinolysis,
Yep.
documented, is it doing more liquefaction or what?
Fibrinolysis, right? Fibrinolysis, remember, is the process by which the body breaks down clots, okay? So if you guys remember in my example over there, all right, there were like 5 of us platelets, right? We were cross-linked together, we formed a stable platelet plug, and then as the coagulation cascade started to activate, a rope formed, which was fibrin, that helps to tie all of us together and strengthen that platelet plug. Fibrinolysis, what it does eventually, is it cuts up that rope into little pieces. So the clot can start to break apart, and it also starts to break apart the molecules that hold the platelets together, that allow them to stick to one another. Like, you remember how we had our arms, so platelets, when they get together to form a plug, they stick together, and I'm going to show you how that works too. Okay, everybody got that?
So it's doing adhesion.
Pardon me?
It's doing like adhesion, like sticking the things together.
Yeah, that's the adhesion part. Yeah, so there's an activation, right? Adhesion and aggregation. Okay? So adhesion can mean a platelet binding to a damaged area of the blood vessel wall. Okay? Activation is the release of these chemical mediators up here that will recruit additional platelets or help to start to build the size of that clot, right? And then aggregation is the process by which two platelets chemically link to one another. Okay? They chemically stick to one another. I'm going to show you how that works. And fibrinolysis will break that chemical bond between them. Okay? I'll show you that in a minute. All right? But all these chemical mediators here are involved in activation. All right? They're involved in activation and vasoconstriction. All right? Here's a better picture, I think, of this, of what I just showed you. I like this one a little bit better. It's a little simpler. It's got a little color to it. Let me show you this just so when you go through this again, you can look at this. Right here, okay, are our endothelial cells in yellow. You see EC there? That stands for endothelial cell, okay? And usually, you can see in this region of the blood vessel, they're nice and smooth, they're intact, everything looks good, but we've got a wall defect here, okay, that could have been caused by trauma to the blood vessel or a ruptured plaque, whatever, okay? The bottom line is that when the endothelial cell that used to be there is destroyed or damaged, we get sub-endothelial glycoproteins here, collagen, shown here in C, and von Willebrand factor, okay? All right? And they will bind to this platelet that is just floating by. That would be me right there in our little scenario, okay? Don't get too hung up on the glycoprotein interactions here. These are two receptors that will bind to these particular subendothelial glycoproteins, but they do stick together, okay? And the platelets have specific receptors that will interact with collagen and von Willebrand factor, and I mentioned some on the previous slide, and you see them here. Now, once I stick to the subendothelial glycoproteins here, I get activated. This platelet is getting activated and turned on. Platelets, normally when they're circulating, are deactivated and quiet. But when they come across a damaged region of the blood vessel wall and they stick to it, they become active. And as part of that activation process, they release ADP, thromboxane A2, and serotonin. You see it released here into the blood? Okay? That's our chemical signals asking for help. Okay? And you can see here is a second platelet that just happens to be right there. And these chemical signals interact with their own unique receptors here on the surface of the platelet. And this little platelet gets activated. Okay? And look what happens. It starts to release its own chemical activators. Again, serotonin, ADP, and thromboxane A2. Everybody see that there? But a second thing happens that's really important. Not only do we have this degranulation going on here, but these two platelets are going to undergo something we call cross-linking. Remember how we had our arms like this and we joined our arms like this, okay? That was representative of this cross-linking, okay? And you can see there's a little molecule here. See this little molecule right here? This is fibrinogen, the monomer of fibrin, okay? And that helps us that binds to, the fibrinogen binds to a glycoprotein 2B3A receptor on this platelet, and causes it then to stick together, okay? And that's aggregation. If these platelets didn't stick together, okay, you might get a couple that bind here, right? But you could never build a big platelet plug that would hold together because the blood would just sweep away the platelets, right? So they have to stick together, and they stick together through the process of cross-linking. Guess what? We have drugs that will block that, okay? We're gonna talk about that, all right? We have drugs that will block at least 2 out of 3 of these mediators here, okay? And all that is done to prevent this process from happening in the coronary circulation, okay? 2 other things I want to point out here just to orient you, okay? Number 1, you see this PGI2 here? That's a prostaglandin. It's normally released by endothelial cells that are healthy and functional. And that prostaglandin keeps your platelets asleep, okay? Pretend that it just kind of keeps your platelets quiet and asleep. It's like sleeping gas for your platelets, okay? But when that's gone, because the region of endothelial cells is destroyed, that coupled with the glycoprotein 2B3, the glycoprotein, subendothelial glycoproteins that stick out here, right? Collagen and von Willebrand factor, a combination of those 2 things will wake up your platelets and activate them, and then they start to stick. Does that make sense? Okay? This over here, all I want to show you is all this is trying to show you is that this is secondary hemostasis right here. It's the clotting cascade. And it occurs on the surface of platelets to form fibrin, which will reinforce and strengthen your arterial clot. Okay? So again, understanding this process from a pathophysiologic perspective will really help you to understand how these drugs work. What questions do you have about this? Go ahead, Anderson.
So, and when something has like an ogen, is that you need to break it to function. Fibrinogen.
Yep.
So first comes the fibrinogen, and then the secondary cascade comes and activates fibrinogen to fibrin, and it holds it together.
Exactly.
Okay.
Yeah, so again, we're going to talk all about the clotting cascade in about 2 weeks.
Okay.
Okay, we're going to go through all of this again. But just all you need to know now is that the clotting cascade is number 1, secondary hemostasis. Number 2, the product of the clotting cascade is the production of this fibrin molecule, right? Which sort of acts like a rope to reinforce your platelet plug and hold your platelets together and keep them strong. Okay? Everybody got that? Okay? Don't worry about all this stuff over here, intrinsic, extrinsic pathway, common pathway, clotting factors. I know all that sounds vaguely familiar to you, right? We're going to go through it in detail in about 2 weeks. Okay? Don't worry about it right now. All right? Yes, take Malcolm.
So you said you want the fibrinogen to hold the platelets together so that they become strong, you said, right?
Yep.
So when you're using the drug to stop them, so is it a good thing or not?
Yeah, so again, but this whole process here, I don't want to demonize this process here and make you think that it's a bad thing, okay? If you were to cut your finger, right, on a piece of paper or a pocket knife or something like that, you want this to happen, right? If you're, God forbid, in a car accident, you're bleeding internally, you definitely want this to happen, right? Otherwise you're going to die, right? The problem is that sometimes it occurs in places where we don't want it to, okay? So it may occur in a coronary artery that doesn't have a hole in it, but rather has an unstable plaque that ruptures and activates this clotting system when it's not needed. Okay? Does that make sense? And then what happens is your coronary artery, which is already partially occluded, can very quickly become fully blocked or occluded. Occluded is a fancy word for blocked, in case you didn't figure that out. Okay? Everybody got that? All right?
What's the cause of that? So,
What's that?
what's the cause of that? It would create this cascade where to the point that we use drugs to
Yeah, so again, like I said, if, if you are somebody that, and Dr. Naeem is going to talk about when to use these drugs. We use drugs in a preventative way to prevent this from happening, especially in the heart. There's a downside to that though, right? What's the downside? Bleeding, right? That's a side effect of it. If you're taking drugs that inhibit this process, all right, you may be protecting that coronary circulation, but as a trade-off, your ability to form a clot goes down. It doesn't disappear entirely, but it goes down. It can make it very difficult for you to clot. Okay? Make sense? Okay, good. All right, now, yes.
Just as a statement, you said fibrin is the product of the secondary pathway.
Yes.
What would be the product of the primary pathway?
The product of the primary hemostatic pathway is the formation of a platelet plug. Okay? The formation of just a clump of platelets that form around the damaged region of the blood vessel wall. Okay? Secondary hemostasis produces fibrin, which reinforces that plug and makes it strong and more permanent. Okay? If you're having a hard time understanding that, pretend you're building a house and you're putting a wood frame together for your house, and what you're using to hold your wood beams together is Elmer's glue. Glue. Okay? Is that a real strong adhesive for a house? No. But then you go in and you start to nail those 2x4s together. Those nails are kind of like fibrin. Okay? So they make that connection between those two pieces of wood really strong and stable. Okay? Versus the glue, which is kind of not very strong at all. It'll hold for a second or two, but, right, you really need to reinforce it with something else. All right. This here, okay, just tells you about secondary hemostasis here and the formation of fibrin strands. I've already talked about this, ad nauseum. And then the fibrinolytic system we're going to talk about hopefully towards the end of class today. Okay? Now, this picture here, yeah, and I know we're a little bit over for break, okay? But I want to just show you this picture here really quickly. You do not need to memorize anything on this. You could cross out if you don't want to. The only reason that I include this picture here is because of the electron micrographs up here in the corner. I just want you to see what happens to platelets when they're activated, because it's pretty dynamic, the change that they go through. Okay? You take a look at this first panel here. This is what resting platelets look like. This is what they look like when they're asleep. Okay? They have a nice round spherical kind of shape to them, right? All right? But when they get activated, either by coming into contact with collagen or von Willebrand factor or thromboxane A2 or ADP or serotonin, they undergo a change in their shape. Okay? This looks almost like kind of an egg that you crack open in a frying pan, right? It starts to spread out. And finally, okay, this is what a fully activated and contracted platelet looks like. They start out like this, but when they get activated, they end up like this. So that chemical activation that occurs is not only chemical in nature, but it's also physical in nature. The platelets actually change their shape or morphology as they go through that activation process. The rest of this right here, folks, is just a reiteration of what I've told you 3 or 4 times now. It's just a different cartoon picture. Like I said, you don't need to know anything on here. And you don't even need to know this. I just wanted to show you this because I thought it was really interesting for you to kind of see what happens to these platelets physically when they get exposed to collagen, von Willebrand factor, or any of those chemical substances that our platelets release to help call in for help. Okay? All right. When we get back, we'll talk about the components of a thrombus and start to get into some of the drugs. 5 minutes today, okay? Just make it quick, go to the restroom, get a drink, stand up, walk around, and then we will get right back into this, okay? I'm here if you have questions.
We're listening to enough and speaking. He said, like, I was like, and he was like, oh, I'm not with him. I was like, what are you talking about?
Olha quem diz hoje.
Honey,
Yes.
I do have a question. So I think I'm kind of confused a little
Yeah.
about when we use this antiplatelet in ischemic heart disease,
Mhm.
because I'm thinking, oh, are the plaques, are they platelets like activated or
No,
what?
the plaques are really, they are, you know what I like to think about? And again, this isn't completely right, but plaques are composed of low density lipoprotein, immune cells that have been converted to foam cells, calcium deposition.
Oh.
So it's when I imagine it like a patch of concrete in your blood vessel. It's there. It's very hard and rigid, right? And again, if it's stable, okay, platelets are less likely to stick to it, although they still can, okay. Or if it ruptures, that's when the platelets can start to really stick to it.
Okay, so these are just preventative?
Yeah,
Like,
exactly.
oh.
Exactly. So your plaques, again, are, things that form slowly over time, okay? And they're composed of many different things, and but they're very hard, like rock almost, okay. And so platelets can stick to them even if they don't rupture, okay. But ruptured platelets or ruptured plaques really do attract lots of platelets very quickly.
That makes sense now, because I was thinking, oh, for like CAD, this already happened. I was linking like platelet formation to plaque. I was like, oh, this already happened.
No, and I'll make sure I clarify that too, so that everybody understands what's going on. Because I don't know that we really talk a lot about that in hyperlipidemia like we should, in terms of the process of plaque formation, what's involved. Okay, but it's really the accumulation of fat modified immune cells, calcium underneath the endothelial layer, and it starts to just form an
Just sitting
unnatural.
right there.
Yeah.
Okay. Not like
Yeah.
Okay.
Okay.
Makes sense.
Yeah.
Thank you.
2-minute warning. 2-minute warning. 2 minutes. All right. So as people are coming back, we're going to start talking a little bit about the different types of clots or thrombi that can form in the vasculature, in the circulation, both in the venous side and the arterial side. Zelka had a great question over break that I wanted to address to everybody because it might be a question that you have, and I think it's super, super important to kind of visualize this process. So we're talking about clot formation, right? You know, in the coronary circulation, typically it's not due to traumatic injury, right? If a clot forms in a coronary artery, it's not because you got a paper cut on your coronary artery or cut it with a knife or something like that, right? It's typically forming because your platelets are sticking to, okay, the rough surface of a stable plaque or sticking to the surface of a ruptured plaque, okay? Plaques are something that are there before the clot forms, okay? So these are, again, when a plaque forms over time as a result of a couple of different pathophysiologic processes, one of which involves high lipids or high cholesterol, right? High LDL levels. We know that excess LDL particles, when there's an extreme amount of LDL in the bloodstream, sometimes some of those particles can slip underneath the endothelial cells and blood vessels, and that begins the process of plaque formation. You'll also get macrophages that will come in to try to clear that up, and they are converted to a modified form called foam cells. And you also get calcium that deposits there, okay? And over time, this forms kind of an unnatural plug or structure on the surface of the blood vessel, okay? The way I like to imagine it is, I like to imagine the inside of a blood vessel, it's nice and smooth, right? And it's shiny, but you've got this clump of concrete that's right there in the blood vessel, sitting on part of the surface of the blood vessel and preventing blood flow. Okay? So again, plaques are something that forms slowly over time, and that platelets can stick to them because they're not smooth and they're not normal or natural like the rest of the blood vessel wall. Everybody understand that? Okay? And I also want to make sure that you're not under a misconception. Platelets can stick to stable plaques, okay? The process is slower, and the formation of a clot could be much slower, but they can still stick to that. A ruptured plaque, an unstable plaque that ruptures, platelets will stick to that very, very quickly, and you can get a full occlusion of your blood vessel very, very quickly that way, okay? And so, again, the drugs that we're about to talk about are all given to prevent a clot from forming in the coronary circulation. As I mentioned before, the downside to that is that you're at an increased risk of bleeding in other areas of your body because you're inhibiting an important part of clot formation, okay? Now, there's two types of thrombi or clots, and this is so important that you know this, because if you don't understand this, you won't understand why we use certain drugs to treat or prevent arterial clots versus drugs that we use to prevent venous clots. They're different, okay? Now, so again, what we have here is most of our clots, especially our arterial clots, okay? Do I have, yeah. You know, there are different things that can make up, any type of clot. You have typically activated platelets, You've got fibrin strands that are produced by the clotting cascade. You'll have red blood cells. So again, if you were to take a clot, kind of pick it apart a little bit, you know, depending on what type of blood vessel it's forming in, artery versus vein, you're going to see different things in that clot, okay? But when we take a look at an arterial clot, this is really important to start this, okay? These form in high blood flow and shear force areas. So again, in the coronary circulation, blood flow is moving fast. There's a lot of it, okay? They can form under those circumstances. They can form when there's turbulent blood flow. So again, if I've got an arterial clot, a plaque in my coronary artery, and the blood's flowing nice and smooth here, and then it hits the clot, and it goes over, okay, that's turbulence, like a plane that bumps in the air. Or if you've ever been along the shore of a river or creek, right? You know, if the water hits a rock, and it goes up over the rock, it gets all foamy and white, all right? So the same thing happens with blood, and that can cause activation of platelets, okay? And endothelial damage, obviously, like a ruptured plaque, okay? Typically, right here, you can highlight this, okay? Arterial clots, like those that form in the coronary circulation, consist of large amounts of activated and aggregated platelets. They're made up primarily of platelets with a small amount of fibrin to reinforce that platelet plug. If we want to prevent arterial clots from occurring, we're going to use drugs that inhibit platelet activation because that's what they're made of, primarily. There is some fibrin there, okay? And we will use anticoagulants as well. But the amount of fibrin that we find in arterial clots, much less than what we see in venous clots, okay? Now, venous clots, and we'll talk about this when we talk about, DVTs, deep venous thrombosis, and pulmonary embolisms and things like that. They form in areas typically where there's only minor or modest damage to the wall of a vein, okay? And can occur where blood flow is very minimal or turbulent, okay? If you have a patient that's bedridden in a hospital for weeks, what do you got to worry about? A DVT forming. Why?
Because of the blood pooling.
The blood's pulling in the legs and it's not moving very fast. Anytime blood kind of stagnates and accumulates in the veins and it's not moving very quickly, you run the risk of a venous clot forming. So how do we treat that? There's a couple of different ways we can do that. We can use drugs, like we can use like heparin or other types of anticoagulants, and Dr. Naeem is going to talk about that. We also have mechanical devices that will squeeze the muscles of the leg, right? You might see this if you've ever worked in a hospital, that again, squeeze the muscles of the leg and just keep that blood from stagnating and pooling in the legs and the veins. It keeps it moving back towards the heart, all right?
Or
Compression socks.
Yeah, compression socks, again, same principle, right? You're kind of squeezing the tissue in the legs, right? And pushing blood towards the chest. I don't know how effective they are with that, but the principle's right. Okay? How many of you, and I know some of you, when you go home for breaks, you have a miserably long flight. I'm not talking like 3 or 4 hours. I'm talking like a day, right? If you're on a plane for 12, 14 hours, okay, you got to really watch. Because again, what can happen is your blood is pooling in your legs. If you don't get up and move around, if you don't move your legs, you could be at risk for developing a DVT, right? And again, if you're a smoker, if you're taking birth control, those are other things, and we'll talk more about that can increase the risk of that happening. And some people are just genetically predisposed to those things.
Can we take a low dose aspirin as part of that type of flight, or is that not how we?
That's a great question. So the question is, if we're taking a super long flight somewhere, we can't get up. We're in coach and we're in the middle seat. We can't get up and flight. Okay. Can we take low dose aspirin to prevent that from happening? The answer to that is no. Okay, now I'm going to explain, that's a fantastic question. I'm going to explain to you why in a second. Okay, if we take a look at a venous thrombus or clot, what is it made up of?
Fibrin.
Fibrin. Will aspirin inhibit the coagulation cascade that makes fibrin?
No.
No. It will inhibit platelets from activating, okay? But the process that produces venous clots is the coagulation cascade, and it's made up almost entirely of fibrin strands, okay? So we don't use antiplatelet agents like aspirin to prevent venous clots. We use drugs that inhibit clotting factors, okay? Does that make sense? That's a fantastic question because it really illustrates, right? If you know what these clots are made of, right, it makes a ton of sense why we use antiplatelet drugs to prevent arterial clots from forming, and why we use anticoagulant drugs that inhibit the clotting factors in the coagulation cascade to prevent venous clots. Okay. Now it is true there's a few platelets that you'll find in venous clots, but they're largely made up of fibrin strands. Okay. Does that make sense? So that's a great question. And again, it illustrates, if you just understand this, everything else makes a lot of sense. Okay? Everybody got that? All right, cool. Let's talk about our antiplatelet drugs. All right, so we just talked about the difference between arterial clots and venous clots, and why it's important to know that, because it can help you understand why we're using the drugs that we use to prevent one versus the other. Arterial clots, like the kind that can form in the coronary arteries, we use antiplatelet drugs to prevent them from occurring because they're made up largely of activated platelets. Our first drug that we're going to talk about, we've already mentioned this before, aspirin. Okay? Aspirin. And Dr. Name will talk to you about about the dose of aspirin that you can use versus what you might use for an antipyretic effect or an analgesic effect. It's much lower, okay? But what aspirin does, here's the chemical structure. I've got no med chem for you, so don't worry about that, okay? Just for you, all right? What it does is it works on the site of the platelet and it inhibits thromboxane A2 production, okay? And that inhibits vasoconstriction at the site of a blood vessel wall damage. It also inhibits platelet activation and aggregation, the activation of the platelets and the linking of the platelets, okay? Think about what thromboxane A2 does. It's a chemical signal that's released by platelets to recruit other platelets and activate them and get them to stick to one another. So if we block that process, okay? If you're interested, okay, here's a picture of how your NSAIDs work, okay, like aspirin. We have arachidonic acid here, which can be converted to thromboxane A2 via the enzyme cyclooxygenase. And again, aspirin will inhibit that enzyme and prevent thromboxane A2, okay, from being produced. Thromboxane A2 that is produced and released by platelets can activate other platelets by stimulating a very specific receptor on the surface of these platelets called a thromboxane A2 receptor. You can see here it's a G protein coupled receptor, okay? And it works through the IP3 pathway, okay, that we learned many moons ago, all right? Now, one of the things that I want to show you down here that's super important, okay, is right here. I want you to circle this part here. That part up there is important. You can circle that part up there. It shows the NSAIDs and the cyclooxygenase. But I also want you to circle this part down here because part of what happens when a platelet gets activated by thromboxane A2, this receptor right here, the glycoprotein 2B3A receptor, gets activated. It changes its shape and increases its affinity for the molecule fibrinogen. And that's what allows platelets to cross-link. So thromboxane A2 is super important in activating the receptor that allows platelets to interact with one another. So let's take a look here, okay? And Ernesto's gonna help me out with this, okay? So let's say, all right, this is my glycoprotein 2B3A receptor right here, okay? And Ernesto's got one too, okay? And we're both inactive. Our receptors are gonna look like this, okay? Closed, not able to bind to anything. Let's pretend I get activated by thromboxane A2 like you see up there. A whole bunch of stuff happens inside of me, and this receptor undergoes a change. It now becomes activated. Okay, you see how that happened? Okay, and now what that allows that receptor to do is bind to this molecule of fibrinogen. Okay, all right? If the same thing happens in Ernesto, okay, all right, he can bind to the other end of that fibrinogen monomer or molecule, and now we're cross-linked together. See how that works? But in order for that to happen, I need to be activated by thromboxane A2. Okay, I can't cross-link with Ernesto unless I get activated by thromboxane A2. My glycoprotein 2B3A receptor right here goes from its inactive conformation to its active conformation. And then it binds fibrinogen, and it interacts with a platelet right next to it that also has gone through the same process. And now we're cross-linked. Everybody see that? Thank you. Appreciate that. All right? All right. Now, we have other types of antiplatelet drugs. So our first group are NSAIDs, aspirin. Okay? The second group of antiplatelet drugs are our purine receptor antagonists. These are drugs that block the effects of ADP. Okay? ADP is another activator of platelets, just like thromboxane A2. Okay? Now, there's a couple of different types of purine receptor antagonists. And they differ kinetically, and it's important for you to know the differences, okay? I don't usually get into kinetics too much and stuff in activation, drug activation, but we're gonna cover it today, okay? All right, so the first drug we're gonna talk about is clopidogrel, all right, brand name Plavix, all right? It's been around for a long time. Clopidogrel belongs to a chemical class of drugs called the thienopyridines, all right? I'm not going to ask you about that on an exam. It's just FYI. Okay? Couple of things. It is orally active, which is important. So it's active as an oral formulation. Now, metabolism here. Okay? I've got a picture of the metabolism on the next slide. What's important about this is that clopidogrel has a relatively slow onset of action, because it requires multiple enzymatic steps in order to be activated, okay? There's a two-step metabolic process, okay? So let's take a look. I'm gonna go back and forth. Here's clopidogrel here, okay? Now, clopidogrel, when you administer it, okay, right off the bat, 85% of the administered drug is deactivated into inactive metabolites. Not so great, right? You're not getting a pretty big yield there from taking the drug, which leaves only 15% of it. All right. Now, clopidogrel will undergo two chemical modifications in order to become active, and they both involve cytochrome P450 enzymes. Okay. Now, there's a couple of these that can catalyze this reaction, but the 2C19 is the most important one that you want to watch out for. Okay, it's involved in both steps of the reaction. Okay, so again, this occurs in the liver. There are two metabolic reactions that need to occur, and so that delays the onset of action. Right, and again, it's via the 2C19 enzyme. That's the important one. Okay, got it? So orally available, slow onset of action. Two metabolic steps it needs to undergo in order to get activated, okay? Okay? Let's talk about another chemical class of purine receptor antagonist, or another group of purine receptor antagonists. The example here is Prasugrel. Okay, it's a third generation thienopyridine. So it's a newer version of this class of drugs. Okay. The first thing about it is that the parent drug, okay, is not inactivated to the same extent as clopidogrel is. Remember, with clopidogrel, you administer the drug, and right off the bat, 85% of it gets destroyed, right? It's deactivated. That doesn't leave you with a whole lot of active drug, all right? With Prasugrel, it is much, much less than that. And it only requires one metabolic step in order to be activated. So it's fast, a much faster onset of action, okay? Again, 2C19 is the enzyme involved in this. So again, we've got two major antiplatelet drugs, right, that are activated via cytochrome P450 2C19, right? What do you got to be thinking about? Drug interactions, right? Other drugs a patient might be taking that are also utilize that enzyme either for activation or deactivation. What else?
Genetics.
Pharmacogenomics, right? What if you have a patient whose liver doesn't make 2C19 very much of it, or it's a mutated form of 2C19, so it's not very active. You see what I'm saying there? So again, what's that? Exactly, right? And so Dr. Naeem is going to talk to you about that, okay? But again, I just want you getting thinking about anytime you've got these cytochrome P450 enzymes involved in either activating the drug or metabolizing it, you've always got to think about those two things. Is your patient taking another drug that's metabolized through that same enzyme? Or is there a pharmacogenomic issue I got to watch out for, okay? All right. All right, ticagrelor is another purine receptor antagonist, but it's a different chemical class, okay? This is a cyclopentyl triazolopyrimidine. How'd I do? Pretty good, right? I practiced that in front of the mirror. I'm not going to say it again because I'll probably mess it up, all right? Now, the advantage of ticagrelor is that it's direct acting. No metabolism required, okay? And it also has an active metabolite that you can see here, okay? And it's got this weird chemical name that I won't ask you to know. I won't ask you a question about this and ask you to identify it. That's just FYI out there. What I do want you to know is that ticagrelor, when it's metabolized, about a third of the parent drug concentration or amount is converted to this active metabolite that also has antiplatelet effects. So we've got no metabolic activation, fast onset of action, and you've got the parent drug in large quantities being converted to an active metabolite that will add to the effect of the parent compound. Okay? Everybody got that? The enzyme that generates the active metabolite, cytochrome P450 Okay? So again, if your patient's taking another drug that's metabolized by that enzyme, okay, will it affect the activity of the parent form of ticagrelor?
Yes.
No. No, because remember, this right here, this form is active right here. But what it will do, maybe this is what you meant when you answered, is that it could potentially reduce the amount of this active metabolite that's being formed. And that could change the patient's response to the drug. Okay, does that make sense to everybody? Okay, so again, complexities in metabolism, all right? So we've got clopidogrel, right? Two-step metabolic process, slow onset of action, 85% of the parent drug eliminated or inactivated upon administration, okay? We've got Prasugrel, okay? Okay, again, it's got one-step metabolic activation, much faster onset of action, right? And then we've got ticagrelor, which requires no metabolic activation, very rapid onset of action, and it's also metabolized, a lot of it's metabolized into an active metabolite that will add to the effects of the parent compound, all right? Now, all three of these drugs have different chemical structures. They all have different metabolic lifespans in terms of what happens to them, but they all work on the same receptor, okay? They're non-equilibrium competitive antagonists of the P2Y receptor. Okay? Clopidogrel and prasugrel bind to the purine receptor irreversibly. Irreversibly. That's what a non-equilibrium competitive antagonist does. It binds to a receptor irreversibly. It sticks to it permanently. Okay? Prasugrel, clopidogrel bind in that way. Okay? And again, if they're on board, once they inactivate that purine receptor, it stays inactive for the life of the platelet. It's dead for the life of the platelet. Okay? Ticagrelor works on the same receptor, but very differently. It's an allosteric antagonist. Remember, we covered this in Module 1, right? I told you were going to see this again. In fact, I used ticagrelor as an example in my notes, not that you would remember, okay? In fact, I'm pretty surprised that I remember that. And I teach it. But it, what it does is, and I'll show you this here in a second, okay? What ticagrelor does, if we go down to panel D here, okay? Well, let's start up here. I'll just explain to you this real quick. Here's your P2Y12 receptor, right? This is your purine receptor that exists on the surface of a platelet that is activated by ADP, one of those chemical activators, okay? Don't worry about panel B. It's just showing it's a G protein coupled receptor. Panel C here is important because this is how clopidogrel and prasugrel work. They bind right to the part of the receptor that normally binds to ADP. You see the parking space up here for ADP, right? Prasugrel and clopidogrel bind permanently to that parking space. And that receptor is no longer functional for the life of the platelet, all right? So it's pretty powerful inhibition. It's like me parking in Dean Shimoda's parking lot permanently, right? And my car can't move. He can't park there anymore. All right? Now, this over here shows you how ticagrelor works, and it's very different. Now, I'm geeking out because I'm a pharmacologist about this. Does it really have any bearing on the clinical usefulness of ticagrelor versus prasugrel or clopidogrel? No. Clopidogrel, no. Okay? There are different, I think it's more the kinetics and the differences there that are probably make up the clinical differences. Dr. Naeem could talk about that, but it does have a very different mechanism of action. It's an allosteric antagonist. It binds to a site of the receptor other than where ADP binds. And when it binds to the receptor, it changes the receptor's conformation so that ADP can't bind anymore. Remember that? Let me show you an example really quick, okay? Let's pretend, I want everybody to look up here for a second, okay? I'll repeat whatever you want. Let's pretend this chair right here is a purine receptor, up there, okay? Now, I'm ADP, okay? I can bind to this receptor, okay? And activate it like this, right? That's what normally happens, and then the platelet that the receptor's on will get activated. Ticagrelor and prasugrel, okay? Let's pretend Ernesto here is ticagrelor or prasugrel. You're going to come over here. You're going to bind to the receptor in the same way that ADP does, with two differences. One, you're not going to activate the receptor when you bind to it. And two, you're going to bind irreversibly to this chair. So you sit down in this chair, you're stuck in this chair forever, okay? This chair can no longer bind to ADP. Everybody see that? Now, ticagrelor is really cool, okay? It's a drug, pretend I'm ticagrelor, right? And I'm coming over to the receptor. I'm not going to bind to the receptor here. I'm going to bind to the receptor here and change its conformation so that nobody can sit in this chair. I'm sitting here holding this down. Nobody can sit in this chair. You see what I'm saying there? It changes the shape and conformation of the receptor so that ADP can't bind to it and activate it. So it's a great example of an allosteric antagonist, all right? So clopidogrel and ticagrelor, kind of our older drugs. bind to the receptor in a very traditional way, but they do so irreversibly. Okay? Ticagrelor is an allosteric antagonist. I may have misstated. Prasugrel and clopidogrel bind like this, like a classic antagonist does. Ticagrelor is an allosteric antagonist. Okay? But the bottom line is no matter how they bind, they both inhibit platelet activation. Okay? So if I'm a platelet here and I bind to this damaged area of the blood vessel wall and I start releasing ADP, that all of the platelets around me have their purine receptors blocked by one of these three drugs, they're not going to respond to that. Okay? But they could respond to what? What else am I releasing besides ADP? Thromboxane A2, right? It could respond to that, or serotonin. Okay? So using these drugs doesn't completely shut down the ability of platelets to bind with one another at a site of damage, okay? But it slows it down and it limits it, okay? All right. This here, you can just exit out. We don't need to worry about this, okay? Everybody Xing here? We're Xing. We're Xing. We're Xing. Get rid of it. All right. This is a table here that just summarizes the similarities and differences between the three purine receptor antagonists that we talked about. Okay?
For these drugs, we need to know like the receptor that they are like.
So you should know, absolutely, that's a great thing. So you should know the receptor that they block. It's the purine receptor, okay, or P2Y12, or the P2Y12 receptor, okay, purine receptor. If I have an exam question on that, I'll try to remember to include both, okay? You should know that clopidogrel and prasugrel, okay, are competitive antagonists that bind irreversibly, and that ticagrelor is an allosteric antagonist, okay? You should know that 2 out of 3 of these are prodrugs, okay? How many steps are in the activation, okay? And the major cytochrome P450 enzyme that's involved, the 2C16, all right? 2C19, I'm sorry. Half-life, don't worry about half-life. Type of binding goes along with the type of antagonist, okay? Onset of action, okay? I don't want you to know numbers because I don't know how clinically accurate these numbers are. Dr. Naeem might talk about this, but what I do want you to know is clopidogrel, its onset of action, slow, right? Versus prasugrel and ticagrelor, fast onset of action. Everybody got that? Okay, good. All right, and then, don't worry about offset of action or relative potency. I'm not worried about those either, okay? Got it? And the bottom line is they all prevent platelet activation or limit it, okay? All right. Now, another group of drugs we're going to talk about are our glycoprotein 2B3A inhibitors, okay? These drugs prevent platelet cross-linking during clot formation. Remember what happened with Ernesto and I and the laser pointer here and advancer, right? Okay? So all we've done is to develop drugs that will bind to the glycoprotein 2B3A receptor and prevent fibrinogen from binding to it. Okay? That's it. All right? Here you can see 2 cartoon activated platelets. These are our glycoprotein 2B3A receptors, and there's a molecule of fibrinogen. Okay? Me, Ernesto, and the laser pointer right here. Okay? And that's how platelets stick to one another when platelets are formed. Okay? Glycoprotein 2B3A receptors have two conformations. They have an inactive conformation. Those receptors are inactive and quiet when the platelet is at rest and sleeping. But when the platelet gets activated, the process of activation causes the glycoprotein 2B3A receptor to assume an active conformation that allows it to bind to fibrinogen with high affinity. Okay? Once that happens and fibrinogen binds, okay, I'm ready to cross-link. Here's my receptor, here's fibrinogen. I'm cross-linking and binding with our nesto now. Okay? And we've got two platelets. I've got other glycoprotein too. I got another one over here. Okay? So I could bind with another platelet around here if I had fibrinogen molecule. All right? All this picture shows, okay, is the process by which your glycoprotein 2B3A receptors get activated. Okay? Here's a resting platelet, okay, that's being acted upon by all of these things here, thromboxane A2, thrombin, ADP, collagen, and that platelet becomes activated. Your glycoprotein 2B3A receptor undergoes a conformational change that increases its affinity for fibrinogen and allows fibrinogen to bind to it. And you can see these two activated platelets are linked together. Okay? That's cross-linking. Now, drugs that prevent this. Abciximab is our first drug. This is a monoclonal antibody that targets and binds to that glycoprotein 2B3A receptor. Okay? This drug is administered parenterally because it's a monoclonal antibody, and it irreversibly binds to the glycoprotein 2B3A receptors, and it prevents platelet cross-linking. If your platelets can't cross-link, that platelet plug that's being formed is unstable and it won't stay together. It'll just get washed away. All right? So abciximab, monoclonal antibody. Okay? Here's another cartoon picture of, a glycoprotein 2B3A receptors here and fibrinogen and how they're linked together. So if you like this picture, you can show that, you can see that. Okay? Okay? Eptifibatide, and I always mispronounce this. I think it's eptifibatide. Eptifibatide? No, eptifibatide, I think it is, yeah. With all these drugs that are coming up here, just listen to what Dr. Naeem says, okay? I've been butchering them for years, and it's just become habit now. Okay, integralin, I can pronounce that at least. This is a peptide-based compound. It's actually modeled after a protein found in pit viper venom. All right, and that protein is called a disintegrant protein. So if you're ever bit by a pit viper, okay, and you're dying, okay, at least you'll understand how you're dying. It prevents your platelets from cross-linking, and you'll bleed to death. Okay, yeah, that's what pit vipers did. Okay. So we've taken advantage of that, and we've taken that very toxic protein or peptide that's made in pit viper venom, and we've modified it to make it less toxic, but more therapeutically useful. And this is where eptifibatide comes from. Okay. Here's the molecule here. It is it's a heptapeptide. Okay. And it's this peptide is in a cyclic formation, it's cyclized. Okay. And there's a disulfide bridge here that you'll see right down here. There's the disulfide bridge that holds this peptide in a cyclic formation. So it's in a circle, essentially, and the circle's connected at either end by this disulfide bridge. Okay? Now, there are two particular parts of this molecule that are in red and blue that are important for binding of this molecule to the glycoprotein 2B3A receptor. Okay? This amino group here and carboxyl group here are important, as well as this lysine molecule, okay? Super important binding points between this drug molecule and the glycoprotein 2B3A receptor, all right? Okay, tyrofibin, okay, is another, I know we're just about out of time. Hang in there for can you hang in there for 2 seconds, okay? I want to get through. This is another synthetic molecule that's based upon the disintegrant proteins in pit viper venom, okay? Much smaller than the tip of a batide, okay? The amino group here and carboxyl group here are critical for the molecules binding to the glycoprotein 2B3A receptor. Very analogous to these two here, all right? So again, eptifibatide and tyrofibin bind reversibly to the glycoprotein 2B3A receptor, unlike, okay, epsiximab, which binds irreversibly, okay? You can see here it just prevents all this cross-linking from occurring and aggregation, okay? All right. So this is where we're going to stop. This is what you're responsible for on the test, okay? We did not get through fibrinolytic agents. We did not get through just basic discussion of heparin. Okay? What I may try to do is record that part. If you want to listen to it just because you're curious or you want to get fill in the blank, great. I will not be asking you any questions about TPA, okay, which is a fibrinolytic agent, or heparin, low molecular weight heparin. Okay, I'll save those questions for 2 weeks from now when we get into the DVT-PE lecture. Okay, everybody got that?
Yes.
I know it's a lot of material. Please, if you have questions, come and see me. Okay. All right, thanks for hanging in there, folks. I appreciate that. Thanks for being here, okay? And I'll catch you guys in a little bit. I think our next subject I'll be teaching you is heart failure, right? Okay?
Thank you.
You're welcome, thank you. Well, we got through the important stuff, okay? We're definitely okay.